This program is brought to you by Emory University.
Good morning, everyone, and happy Friday. Thank you so much for joining us this morning. This morning, we have Hiroki Ueyama, who is one of our fellows on our clinical investigator track. He's in his first clinical year this year. He did his medical school in Japan and his residency at Mount Sinai, and we are lucky to have him here, and he will be pursuing interventional cardiology as a career. It's all you, Hiroki.
Thank you. Thank you everyone for joining. I'm Hiroki, one of the clinical investigator track fellow, now in the first year of clinical training. And I did my research years with the structural heart team. And as you all know, the structural heart program here at Emory is well known, nationally and globally. And one of the reasons for that is that this program, with collaboration with the team at the NIH, really kind of invented and pioneered and pushing forward the field of what we now call the transcatheter electrosurgery. And I think we as a fellow here have the opportunity to take care of patients who underwent various transcatheter electrosurgery procedures, primarily perhaps in the Midtown CCU, where patients occasionally gets admitted post-procedure for close monitoring. So I thought it would be nice to give an overview of what transcatheter electrosurgery is. So the goal of this presentation today is to first discuss the principles and basic physics of transcatheter electrosurgery. Second, to review the indications and clinical applications of various forms of transcatheter electrosurgery. And third, to analyze the data supporting the use of transcatheter electrosurgery. I will start with a case presentation. The patient was an 80-year-old female who presents to the clinic with chief complaints of having shortness of breath. She was actually a well-known patient to the structural heart team. She had a history of severe aortic valve insufficiency and had a surgical aortic valve replacement using the freestyle valve, which is a stentless porcine valve that was implanted 12 years ago, which subsequently degenerated and underwent valve-in-valve TAVR with a SAPIEN 3 valve 2 years ago. And she initially felt much better after valve-in-valve TAVR and was able to do all her daily activities without limitations. But after a year, she noted a decline in her symptoms, and she noticed that she's been easily out of breath, having to stop in between while walking from room to room. Her daughter would notice her being extremely out of breath after taking a shower, and she needed about 3 to 4 pillows at night to breathe better. She didn't have much of a leg swelling, but would notice some leg swelling at the end of the day, which would resolve in the morning. And she was admitted twice in the past year to an outside hospital for what sounded like an acute decompensated heart failure episodes. Other than her history of aortic valve replacement, she had a three-vessel CABG that was done at the time of surgical aortic valve replacement that was known to be patent recently. She had a history of complete heart block and a pacemaker implantation a year ago, and a history of hypertension, hyperlipidemia, diabetes, and CKD 3B. So the echo was done, and which showed a preserved LVEF and normal functioning bioprosthetic aortic valve without valvular or paravalvular regurgitation. But notably, as you can see here, she had a very thick ventricle with interventricular septum measuring 1.8 centimeter and the posterior wall measuring 1.4 centimeter and associated with a very small LV cavity. You could also appreciate the severe mitral annular calcification, with calcification kind of appearing to be extending into the leaflet with restrictive motion. And as in the picture on the right, on multiple views, she was noted to have an LVOT gradient reaching 40 at rest and 60 with Valsalva, suggesting an obstructive physiology. Here you can see a clear aliasing of color Doppler at the level of mitral valve and diastole with mean gradient across the valve measuring 20 millimeter mercury at a heart rate of 74, suggesting a severe mitral stenosis. And there's no significant mitral regurgitation. And on the picture on the right, is showing the max TR pressure gradient of 54, again suggesting an elevated estimated right ventricular systolic pressure and pulmonary hypertension. So the structural CT was performed, and you can see that there's, you can see a prior sapien 3 valve that is well positioned, and even see the biprosthetic leaflet moving very well and thin and not thickened. You could also appreciate the LV function appears to be preserved, but the LV wall is very thickened, and the left atrium looks enlarged. Uh, Notably, you can see again the severe mitral annular calcification, and on the picture on the right, you can see a near circumferential severe MAC. So at this point, her symptoms were thought to be due to combination of her MAC-related severe mitral stenosis as well as LVOT obstruction. And her case was obviously very tough. She had extensive comorbidities, including prior sternotomy for AVR and CABG, had a CKD 3B, as well as significant pulmonary hypertension from her left-sided heart disease. And in the multidisciplinary heart team meeting, it was thought that she is at prohibitive risk of surgical approach for both her mitral valve disease as well as LVOT obstruction. But her symptoms were really debilitating, and her quality of life was significantly impaired to the point that patient really wanted something to be done. So transcatheter approaches were considered and thought that a transcatheter septal reduction therapy for LVOT obstruction and valve-in-mac TMVR or transcatheter mitral valve replacement could treat her symptoms. So the traditional approach for septal reduction therapy, which is the alcohol septal ablation, was first attempted. You can see the guide wire being advanced in the desired first septal perforator artery, which is supplying the basal septum. But from here on, it was very difficult to deliver the balloon into the septal branch that is needed prior to injecting the alcohol for septal ablation. And multiple maneuvers were tried, but none of them was successful in subsequently delivering the balloon. So eventually the procedure had to be aborted. So at this point, after repeated multidisciplinary heart team meetings, she was anatomically thought that she would be at high risk of worsening LVOT obstruction if she were to undergo TMVR without septal reduction therapy. And therefore, it was thought that a novel transcatheter electrosurgery approach for septal reduction with sesame, followed by lampoon and TMVR, was needed. And here I think question arises, what is sesame, what is lampoon, and what is transcatheter electrosurgery? And here I would like to give an overview of transcatheter electrosurgery, starting from the basic principles and then introducing variety of transcatheter electrosurgery procedures and its actual clinical applications. So the transcatheter electrosurgery is really a novel field in structural heart intervention that was pioneered here at Emory with collaboration at the team at NIH, and it employs a technique of delivering a focal radiofrequency to the tissue and thereby allowing traversal or laceration of the tissue within within the body, including blood vessels and valve leaflets and even myocardium. And I think it's important to note that there's a niche of patients that we encounter in our daily practice in whom traditional approaches are thought to be inadequate or thought to have prohibitive risk or even tried but unsuccessful, and yet the patient is symptomatically in high need of doing something else to maintain their quality of life. And transcatheter electrosurgery was really inspired and developed to meet these patients' demand. And each of these procedures here and ideas were initially developed when the team here was trying to find out a way to help a patient without traditional options. And the picture here is an example of the procedures that employ transcatheter electrosurgery, and it's shown in the chronological order of its development. And I'll be explaining about some of these procedures in detail later. But briefly, the transcaval axis is a technique to traverse from the inferior vena cava into the abdominal aorta for large bore axis. The lampoon is a technique to lacerate the anterior mitral leaflet prior to transcatheter mitral valve replacement. And this is notably the first application of transcatheter electrosurgery to lacerate a tissue within the human body. Basilica is a technique to lacerate the native or biprosthetic aortic valve leaflet prior to TAVR. Elasticlip is a technique used when needing a transcatheter mitral valve replacement in patients who had a prior mitral clip or edge-to-edge repair, and we lacerate the anterior mitral leaflet to pin the clip to the posterior mitral leaflet in order to do a subsequent TMVR. And sesame is a technique to lacerate the septal bulge. And then the cleft is the newest development in this field and is a technique to lacerate the mitral leaflet commissures for patients with rheumatic mitral valve stenosis. And before I go into the details of each procedure, I'd like to review the basic physics of electrosurgery to understand the mechanism of how it works, but also to understand the safety of the procedure. So electrosurgery refers to a delivery of radiofrequency range alternating current, which is very fast, about 500 kilohertz to cut the target tissue. And this is most commonly used during surgery when surgeons use a handheld active electrode, which is usually the Bovie pencil, to cut or coagulate the tissue. And I think everyone have seen them used during the surgery. And electrosurgery can be performed in a monopolar or bipolar configuration, and the monopolar being used most commonly in transcatheter electrosurgery. The picture on the right here shows the monopolar configuration, where current flows in a circuit from an active electrode to the target tissue, then through the patient's body and back to the electrosurgical radiofrequency generator via the dispersive electrode on the patient's skin. And the active electrode during the traditional surgery is the tip of the Bovie pencil, whereas in transcatheter electrosurgery, it is the tip of the guide wire or the configuration we call the flying V, which I'll be explaining a little bit later. But the equal current flows from the active electrode to the dispersive electrode. But the contact surface area of the active electrode is obviously dramatically smaller, and therefore the energy is concentrated here. And the tissue adjacent to that active electrode becomes resistant to the current flow, which then converts electrical energy to a heat. And in the electrosurgical pencils used for surgery, there's a cutting mode and a coagulation mode, as in this picture on the left. And the cutting mode, which is used for transcatheter electrosurgery, a radiofrequency energy is delivered in a delivered continuously to the active electrode, which then causes a rapid focal heating above 100 degrees Celsius at that tissue, which then vaporizes the cells and therefore cuts the tissue. And this is importantly different from the coagulation mode, which gives an interrupted current delivery, which causes rapid heating and cooling cycle that allows blood to coagulate. And this is obviously undesired in transcatheter electrosurgery because it may risk stroke and other thromboembolic events. So again, the cutting mode is used for the transcatheter electrosurgery. And there are two main purposes of transcatheter electrosurgery, to traverse or to lacerate the tissue. And figure on the left shows the configurations to traverse the tissue. We use a guide wire used for coronary intervention to deliver our radiofrequency to the target tissue. And most guide wire have this polymer coating that acts actually as an electrical insulator. So using the scalpel, the proximal back end of the guide wire is selectively denuded from the insulating coating, and this part is clamped to the electrosurgical pencil using the hemostat. And then the distal end often have this long uninsulated distal metallic tips. And we know that the electrical circuit is prone to dispersal of current when it is exposed to the blood, as in this simulation on the right. So we create this coaxial system involving the microcatheter and wire converter to further insulate the guide wire until the very tip of the wire that engages the tissue and acts as an active electrode of the circuit. And that way we could concentrate the charge just at the level of tissue traversal, and this is fundamental in success and safety of transcatheter electrosurgery. Now, when lacerating the tissue, the back end of the guide wire is configured in the same way and attached to the electrosurgical pencils. But for laceration, instead of delivering radiofrequency to the tip of the guide wire, it delivers a radiofrequency to the mid shaft of the guide wire. And how it does that is the guide wire is kinked at the mid shaft, and the inner curve is focally denuded by scalpel. And this becomes the active electrode and the cutting edge surface, where the radio frequency is focally concentrated, and we call this configuration the flying V. And then the both side of the flying V is further insulated by a microcatheter to again avoid dispersal of current energy. And once this configuration is delivered to the target tissue, the both end of the catheter is pulled while applying radio frequency to allow for the tissue laceration. So that's the basic physics of the radiofrequency or transcatheter electrosurgery. And looking at the history of transcatheter electrosurgery, the very first clinical application was actually in 1993 in a pediatric field where transcatheter electrosurgery was used to assist pulmonary valvulotomy for a patient with pulmonary valve atresia. However, more advancement happened more recently in the past decade, coinciding with evolution of structural heart interventions such as TAVR and TMVR. The transcaval TAVR was first reported in 2014 and the IDE trial in 2017. Then Lampoon, Basilica, Elasticlip was reported, each trying to address difficult and complex patient population associated with transcatheter therapies. Then the first case of Sesame was more recently reported in 2022, and a large retrospective study was just reported last year, and more are coming. And important note here is that each of these procedures were not only reported as a first-in-human study, but also, tested in a rigorous IDE trial to confirm its safety and efficacy, and I'll introduce some of it today. So I'll plan to introduce a couple of the common clinical application of transcatheter electrosurgery that you would likely encounter in this program during the fellowship. First is the transcaval access, which is essentially accessing the aorta from the IVC to allow large bore access delivery. And this involves electrosurgery to traverse the blood vessel. So TAVR is performed generally through transfemoral access, in which femoral arteries is accessed from the groin and large bore access sheath is inserted. And it generally requires a minimum of about 5 to 5.5 millimeters throughout the pathway in order to deliver the device safely. However, there are patients who, from a variety of reasons, including, peripheral artery disease, that has small arteries that preclude standard transfemoral access. And registry data have shown that about 5% of all TAVR cases require alternative access. And there are other alternative access that has been used for TAVR. The transapical axis, in which the axis is created from the LV apex, was used more in the initial experience of TAVR, but has consistently been shown to be associated with a higher rate of complications and even mortality. So nowadays, rarely performed. And other options include transcarotid or transaxillary, but these require surgical cut down and ergonomically different from the transfemoral axis, so may be difficult for the operator. So the transcaval axis was developed to overcome these limitations. And here on the left is a schematic of how it is performed. The femoral venous axis is obtained, and the catheter, usually the IM catheter, is advanced facing toward the abdominal aorta. And on the aorta side, the gooseneck snare is advanced at the same level, open, awaiting for the guide wire to come in. Then the electrosurgery is applied at the tip of the guide wire to traverse from the IVC to the abdominal aorta, which is then ensnared, creating the rail to then advance the large bore delivery system. Then the TAVR is performed in the usual fashion, and after the TAVR is finished, the hole between the IVC and the abdominal aorta is closed using the Amplatzer ductal occluder. And on the right is the actual fluoroscopy image, and here you can see the guide wire advancing and traversing from IVC to the abdominal aorta, which is then being ensnared, and the connection has been created. And this is now advanced cephalically, and now you can see the microcatheter being advanced and the rail being created, allowing for a more stiff wire to be delivered. Then the TAVR is performed in a usual fashion. And after the TAVR is done, you can see the hole being closed with Amplatzer ductal occluder. And I think the natural question or concern when hearing about this approach is, what if the hole was not successfully closed, and would it be at risk of significant hemorrhage? And here there is a physiological principle of why this is still thought to be safe. So the both aorta and the IVC is within this retroperitoneal space, and there is a difference in hydrostatic pressure between aorta, retroperitoneum, and the IVC. And aorta is, let's say, about 100 millimeter mercury, and retroperitoneum is about 20, and IVC is about 10. So there's a constant gradient here, and the blood flows from the highest to the least pressure, which allows the blood to flow seamlessly from the hole in the descending abdominal aorta and drained into the inferior vena cava, and thereby minimizing the extravasation and accumulation of the blood into the retroperitoneal space. And on the right here, you can see the actual, case of contrast directly flowing from the abdominal aorta into the IVC without any extravasation. So this was tested in a prospective multicenter single-arm ID trial involving 100 patients undergoing transcaval TAVR. It enrolled a very high surgical risk population with SDS perioperative mortality of 9.6%. And these patients were all thought to be not a candidate for the traditional transfemoral axis or the transaortic or the transapical axis. And in these patients, successful transcaval axis was achieved in 99%, which then allowed for subsequent TAVR. And there's no mortality that was directly attributed to the transcaval axis, and none required emergency surgical rescue of the transcaval axis site. And the table here shows the frequency of retroperitoneal hematoma and presence of aortocaval fistula. I think the data here is interesting. With routine post-procedure CT by protocol, the retroperitoneal hematoma was actually observed in 24% pre-discharge, but most was very small, and only 5% had it by 30 days. And there's a 12-month follow-up study published which aimed to investigate if there were any late-term complications from transcaval axis. And here on the right, you can see that the proportion of proven occluded aortocaval fistula by CT has increased over time. It was 33% post-procedure, increased to 49% pre-discharge, 66% at 30 days, and 86% at 12 months. And importantly, the fistula patency was not associated with survival, heart failure hospitalization, aortic rupture, or late retroperitoneal hematoma. And these suggest that the fistula may still not be closed immediately, but most close spontaneously over time, and it is not associated with any clinical meaningful adverse outcome. Also, the aortic cross-sectional area at the level of traversal was assessed by CT over time and did not change over time, suggesting that it does not affect the integrity of the abdominal aorta. And subsequently, the transcaval axis TAVR is compared with the traditional transfemoral axis and the transaxillary axis in a retrospective multicenter analysis involving more than 7,000 patients. And the study showed that in general, the complication rates were higher in alternative axis TAVR, which include both transcaval and transaxillary axis TAVR, compared with transfemoral axis, which is expected as these patients are generally more sick. But notably, the rate of stroke and TIA was significantly lower with transcaval axis compared with the transaxillary axis, 13% versus 3%. And the rate of vascular complications and bleedings and mortality was similar between the transcaval and transaxillary axis TAVR, supporting the transcable axis as an attractive option for alternative axis TAVR. And next up is the basilica, which is a procedure to lacerate the biprosthetic or the native aortic valve leaflet immediately prior to a new valve or implanting a new TAVR valve to prevent coronary obstruction. And a coronary obstruction is a rare complication of TAVR with less than 1% of the total TAVR population, but it's associated with a very high mortality reaching as high as 40%. And it is more commonly seen in valve-in-valve procedure from 2 to 3%. And the mechanism of how the coronary obstruction occur after TAVR is shown here. This is the common SAPIEN 3 valve we use for TAVR. It consists of this inner and outer skirt, which is designed to prevent perivalvular leak. And there's this stent frame and stent struts. And when the TAVR is implanted in the aortic valve position, it actually pins open the original leaflet, which now covers the stent frame and stent struts, making it essentially a cylinder in the sinus. And when the sinuses are small in terms of its width or the height, the cylinder can obstruct the coronary ostia. And basilica is used to present this in a patient who their risk of developing coronary obstruction after TAVR is thought to be high. There are several risk factors that are known to predict coronary obstruction after TAVR, such as low coronary height, narrow sinus width, long biprosthetic leaflet, or low SDJ height, lower than the length of coronary leaflet. And in case of valve-in-valve TAVR, the externally mounted biprosthetic valves, such as the trifecta or mitral flow valve, are notorious of higher risk of coronary obstruction. In all TAVR planning using CT, we measure this virtual valve to the coronary distance, which is VTC, and the virtual valve to the STJ junction, which is called a VT-STJ. And if these are lower than 4 or 2 respectively, they are again thought at high risk of developing coronary obstruction after TAVR. And this is a cartoon of the basilica procedure. In a retrograde fashion, the catheter is advanced to target the leaflet, and the leaflet is traversed using radiofrequency, then ensnared. Then this flying V configuration is used to lacerate the tissue. And here now you can see the leaflet is split so that the coronary ostia is not covered when the TAVR valve is implanted, as compared to the coronary ostia completely covered, causing obstruction without basilica. This is the actual case, and you can see the catheter pointing at the base of the cusp and the snare awaiting in the LVOT. Then the leaflet is being traversed and captured by the snare. And it's going to be externalized to deliver the flying V. This is the configuration we call the flying V, and you can see it's being used to lacerate the tissue. And immediately afterwards, the TAVR valve is implanted. And with this angiogram, you can see that there's no coronary obstruction after the TAVR. So basilica was also initially tested in ID trial and shown its safety, and with more and more valve-in-valve procedures being done, the need for basilica to prevent coronary obstruction is increasing, and it's really done globally now. And this is a retrospective, multi-center international registry of 200 patients undergoing basilica. And in this study, the successful basilica traversal and laceration and freedom from coronary obstruction was achieved in close to 95%. And on the initial IDE trial, there was a concern of potential high risk of stroke, but in this multicenter registry, the risk of 30 days all-cause stroke was 2.8% and disabling stroke was 0.5%, which is comparable to the all-comer traditional TAVR not requiring basilica. And now lampoon is another electrosurgery procedure with somewhat similar concept with the basilica, except here it is the mitral position and it lacerates the anterior mitral leaflet, trying to prevent LVOT obstruction after transcatheter mitral valve replacement or TMVR. So lampoon is indicated to prevent LVOT obstruction. LVOT obstruction occurs in a mechanism similar to coronary obstruction after TAVR. Here, when the transcatheter valve is implanted in the mitral position, the native anterior mitral valve leaflet is pinned open to cover the stent struts, resulting in, again, a cylinder now protruding into the LVOT against the interventricular septum and risking the LVOT obstruction. And from early experience using the sapien valve for valve-in-valve or valve-in-ring or valve-in-Mac TMVR, the LVOT obstruction actually occurred in about 7%, and it was significantly more common in valve-in-Mac TMVR reaching 40%, and it was associated with a very high mortality reaching 50%. So consequently, the risk of developing LVOT obstruction has been the leading cause of screen failure for TMVR trials, and lampoon was developed as one of the strategies to prevent this LVOT obstruction by performing it immediately before TMVR. This is again the cartoon of the lampoon procedure. The catheter and the snare is advanced and leaflet is transversed using radiofrequency. It's ensnare and the flying V is used to lacerate the anterior mitral leaflet. And you can see that with lampoon, the stent struts are open to allow the blood to flow through. This is looking from the LVOT view. And again, you can see that the stent struts are open after lampoon, allowing the blood to go through. Now, diving a little bit more deeply into LVOT obstruction and predicting LVOT obstruction after TMVR, because it also relates to the next procedure, Sesame. There are two CT measurements that are done for all patients planned for TMVR. This is CT image and virtual valve implanted in the mitral position. Without the lampoon, all the stent struts are covered by the leaflet, so the LVOT become compromised to the level of this red line. We call this the neo-LVOT, and we measure the cross-sectional area of this level. And if this is small, we have to consider lampoon. Now, if we were to perform lampoon, then the anterior mitral leaflet is now out of the way, but there are still this inner and outer skirt of the transcatheter valve that does not allow the blood to go through. So the LVOT becomes at the level of this blue line. We call this the skirt neo-LVOT. If we also measure the cross-sectional area at this level, and if this is small, we have to consider a septal reduction therapy, essentially to make this LVOT itself larger. This is another schematic explaining this concept, but we now know from our prior studies that neo-LVOT of less than 200 and skirt neo-LVOT of less than 180 is a predictor of LVOT obstruction. And so lampoon was also tested in the IDE trial. It was a prospective multicenter single-arm trial involving 30 patients undergoing lampoon prior to valve-in-ring or valve-in-Mac TMVR. And these patients are, again, high surgical risk patients with STS perimortality perioperative mortality reaching 10.2%. And all patients had successful lampoon traversal laceration, which then allowed all patients to have subsequent TMVR with acceptable LVOT gradient following TMVR. And there's really not much of a complications from the procedure. There are variants of lampoon procedure that was developed with some concern that original lampoon was technically demanding and was difficult for widespread adoption. And so the original one was called the retrograde lampoon, where the catheter is advanced through the aortic valve, which was technically demanding to position the two retrograde transaortic catheter to precisely and to snare a leaflet traversing guide wire in the left atrium. So the antegrade lampoon was developed through a transeptal approach, and this has shown that the procedure time was significantly decreased with this approach. So this led to more adoption of this procedure globally now and is the mainstream of lampoon in the current practice. And lastly, there is this tip-to-base lampoon that can be done in patients who have prior valvuloplasty ring or biprosthetic valve for further ease of the procedure. So, and then last transcatheter electrosurgery procedure that I'll be introducing is called a sesame, which is essentially a transcatheter myotomy procedure, which is the first application of transcatheter electrosurgery that involve intramyocardial navigation of a guide wire and laceration of the myocardium. And sesame is in the class of procedure we call septal reduction therapy, which is performed to treat or prevent LVOT obstruction. And LVOT obstruction largely occurs by two mechanisms. One we all know is hypertrophic cardiomyopathy, and other is iatrogenic LVOT obstruction following TMVR, as we kind of went through when discussing about lampoon. And there are traditional septal reduction therapies such as surgical myectomy and alcohol septal ablation, which both have some limitations. The surgical myectomy can be morbid. It requires high operator and institutional expertise. And the transcatheter alcohol septal ablation can be limited by target mismatch with septal artery distribution. And there's non-negligible risk of pacemaker implantation, especially so when performed prior to TMVR. So the sesame procedure was developed to overcome these limitations. And the cartoon here shows the procedural step in which the catheter is engaged in the basal septum. And through that, a stiff guide wire is advanced intramyocardial until it re-enters the LV cavity. Then the guide wire is snared and externalized. And then this flying V is advanced, which then delivers this pinpoint radiofrequency to lacerate the myocardium while the catheter are being pulled back. And this results in this longitudinal splay along the septal bulge, relieving LVOT obstruction. And this is the video of the actual procedure. Procedure is performed with biplane fluoroscopy guided by a TEE. And the basal septum engaged, and you can see the guide wire is being advanced along the pre-planned trajectory. It's ensnared, and the flying V is advanced. And the flying V is now being used to cut the tissue while both end of the catheter is being pulled back. And this is the representative TE image of display. And this is the representative CT of display. And you can see a clear splay both in the short axis and the long axis view. So the procedure was initially performed in a pig model at NIH, and it was offered to patients with prohibitive risk of surgical approach on a compassionate basis. And we just reported our retrospective analysis involving 76 patients undergoing sesame. And the indication of this procedure was either, again, hypertrophic cardiomyopathy patient who already had symptomatic LVOT obstruction despite medical therapy. These were 11 patients, or performed as a preventive therapy to allow subsequent transcatheter valve replacement. These were 65 patients. And obviously, these were, again, all prohibited risk surgery patients. And this is looking at the septal thickness before and after the procedure. And you can see that there is about 50% reduction in the septal thickness in the hypertrophic cardiomyopathy group, as well as pre-TMVR group. On the top here is looking at the changes in LVOT gradient pre and post sesame. And in hypertrophic cardiomyopathy population, there's a significant drop in LVOT gradient after sesame from resting 54 to 29 and provoked 146 to 85, both of which is about 50% reduction. And bottom here is looking at the LVOT area. And when we focus on the neo-LVOT and skirt neo-LVOT, the baseline value of 65 and 169 is very small, prohibiting to perform TMVR. But Sesame successfully increased these values after the procedure to then allow TMVR to be performed safely. So briefly going back to the first case of what happened, the patient had severe macrolated mitral stenosis as well as LVOT obstruction at baseline, and she underwent successful sesame first. And these are the CT images of the short axis, the long axis, and the virtual valve implantation at baseline and after sesame. And at baseline, you can see that there's this significant septal bulge and how the virtual valve is risking the LVOT obstruction.
Did you make 2 more leads?
After the sesame, you can see the clear splay here at the septum, reducing the septal thickness, and the virtual valve is now not risking the LVOT. She also had a baseline LVOT gradient as well. And this is the hemodynamic tracing before and after sesame. And you can see that a significant drop in peak-to-peak gradient both at rest and post-PVC. And she subsequently underwent Lampoon and TMVR at 30 days after sesame. This is the example of antegrade Lampoon, and you can see the anterior mitral leaflet traverse and the flying V lacerating the leaflet. And immediately after that, on the right, you can see the transcatheter mitral valve being implanted in the mitral position and successfully deployed. And lastly, this is again the post-procedure CT, and you can see that the transcatheter mitral valve device implanted nicely as virtually planned without risking LVOT obstruction. So take-home message, first, transcatheter electrosurgery was developed to address the demand for complex patient populations lacking traditional treatment option, and it's still an evolving field, and more procedures are being sought, with procedure being optimized. And just to summarize the common clinical applications of transcatheter electrosurgery that you may encounter during this fellowship, transcaval TAVR is traversing from the IVC to the abdominal aorta to facilitate a large bore access delivery in patients with anatomically unsuitable for transfemoral access. Basilica is splitting the bioprosthetic or native aortic valve leaflet immediately before TAVR to prevent coronary obstruction. Lampoon is splitting the anterior mitral leaflet immediately before TMVR to prevent LVOT obstruction, and Sesame is splitting the septum to treat LVOT obstruction in patients with hypertrophic cardiomyopathy or to prevent LVOT obstruction in patients who are thought to be at high risk of LVOT obstruction after transcatheter valve therapies. And lastly, I'd like to thank all of my structural heart team, including Dr. Babrialis, Dr. Greenbaum, Dr. Letterman, for what they taught me all about transcatheter electrosurgery and structural intervention, as well as their continued mentorship. So thank you very much, and I am open for any questions.
Thanks, Hiroki. That was a really nice review of electrosurgery, especially for those of us who don't get to see it all the time. I will open the floor for comment and questions.
Yeah, I just want to say, Hiroki, great job. I think one of the things that's kind of important to note about these procedures is that we talk about them, we do them often, but there's actually no dedicated equipment for these procedures, right? So these are all done with things off the shelf, so to speak, that are kind of manipulated and changed for the purposes of these procedures, which kind of adds to the complexity and challenges of them. So I think hopefully more dedicated devices coming, but certainly a challenge, an additional challenge for those.
Hiroki, it's Vasilis. Fantastic, great presentation. Hiroki stayed with us for 2 years and learned everything, and you see this sort of progression from this electricity through the catheters, going from adjunct procedures to standalone procedures like Sesame. We're hoping that myotomy might be a standalone procedure for hypertrophic cardiomyopathy. One question for you, Hiroki, you can maybe make a comment, is what is the role of imaging and pre-planning and the role of the imagers in the development of all these procedures or how they facilitate? Maybe you can make a few comments because this certainly looks like an interventional slanted talk, but there's maybe you could point out some of the imaging
Yeah,
importance.
definitely. I learned that a lot of these are really procedural planning. For all of our transcatheter valve intervention procedure, we do structural CT. It really kind of delineates the structure in 3D, and structural CT is needed for pre-planning to risk stratify these patients for complications, including coronary obstruction and LVOT obstruction. And also it gives us information about, for example, Sesame, how the trajectory of the guide wires should go through the muscle before it re-enters the LV cavity to safely perform these procedure, which will then allow the fluoroscopy guidance. And also during the procedure, TE is used for all of these procedures, and we know that having a good imager with a good image during the procedure is the fundamental part about this success of this procedure. And I think we're lucky here that we have great imagers that could really show the picture very well. Yeah.
Stan Sherman, Hiroki, good talk. I just wonder when you're dealing with hypertrophic cardiomyopathy, you've got a hunk of meat there, and that you're cutting through. What happens to the meat? Where would you?
Yeah.
Do you grab hold of it and take it out, or what do you do?
That's a great question. And that's a question we, I think, commonly encounter. And it's actually not cutting away the meat itself, but it's actually like splitting open the meat as like a zipper. And so it actually split open the septum and not removing any of the meat. And by splitting open this bulge, we're able to enlarge the LVOT area and treat and prevent LVOT obstruction that way. And this is like the example of the actual splay. And again, this is not, taken out, but it's just splayed open.
Great presentation. This is very eye-opening, but I just have a quick question. So, since you're like kind of cut open the septum area, do you actually see increased risk of heart block, either like a bundle branch block or a complete heart block after the procedure?
Yeah, so that's also a very good question. And the Sesame, one of the purpose of Sesame was to lower the risk of pacemaker implantation or conduction delay. The other septal reduction therapy that is available from transcatheter approach is called alcohol septal ablation, and that would, essentially cause like myocardial infarction in this area. And we've known that from prior studies that if it's used in a pre-TMVR population, the risk of conduction abnormality or pacemaker implantation was about 10%. So it was non-negligible, it was very high. So this Sesame was designed to kind of avoid that. And how it actually does is actually depicted very well here. The left bundle is actually going through this in between this area of and right coronary cusp, whereas we intentionally plan to go through this myocardium between the left and right cusp, and thereby kind of avoiding the left bundle. And our pacemaker implantation rate after Sesame in a retrospective analysis of 76 patients is very low. I think it was about 2%. And also these most commonly happen after concomitant TAVR procedure. So that was probably due to TAVR. And so there is very low risk of developing a conduction abnormality after Sesame because we intentionally avoid this area. And that's a very good question.
Gotcha. Very cool. Thank you.
Hiroki, it's Robbie Williams here. I think you actually sort of undersold the heart block risk in alcohol septal ablation, which is a very effective means of reducing left ventricular outflow tract obstruction. But in most people's data, it's probably closer to 20 to 25% in all comers. And if patients have underlying left bundles before, it's probably even higher. So for alcohol septal ablation of heart block.
So this is Spencer King. I got in a little bit late, and I don't know if you covered this, but so when you cut something, cut tissue, sometimes it grows back together. I mean, how long a follow-up, and what do you know about the healing aspects of this?
Yeah, so for Sesame, we have a certain degree of follow-up data. Some patients have CT up to 12 months, and we have not seen any grow back of the tissue. What we notice is that the sesame width becomes a little bit larger by 30 day, and then after that it kind of stays that way. And we have not seen any patients who actually have a development of a kind of scar tissue or an area where there's regrowth of the tissue. So that's interesting. We have CT scan up to 12 months for about, I think, 30% of the patients who underwent Sesame in the first 76 patients. But with the prospective trial, we are hoping we could do CT for all patients and have more idea about what actually happens to display. But so far, from retrospective analysis, we're not seeing that kind of things.
That's good news.
Hiroki, one comment. This is Mahmoud Abdu. Fantastic presentation from absolutely amazing and fantastic structural team. One comment I want to hear from either you or any of our team members is with the improvement of multimodality imaging and a lot of success so far with these procedures, where is the future? What is in the pipeline that's coming in the next 5 to 10 years? And will we be seeing any more advancing? Where do you think we are lagging behind in technology?
Yeah, I think I'll take the question first. In terms of its relationship with like multimodality imaging, as kind of discussed, structural CT imaging is very important in planning. Also, I think what we're trying to understand from specifically the Sesame procedure, the role of cardiac MRI to see to characterize the septum a little bit better, to see what patient population is appropriate and or at high risk of these procedure. And I think the cardiac MRI will have the potential to guide us through that. I'm not sure if Dr. Vavrios or Dr. Gleason or anyone else in that line could join in.
But let me add just a few more things. Sending electricity through the catheters is, the EP guys do that, but now we're using it to try and recreate surgical procedures so that we can cut, ablate, lacerate, but ultimately even remove leaflets, maybe to Stan's point, remove myocardium, not just fillet it. So, stay tuned for more things that look like stitching and complete removal and so forth. I mean, people have done, myxoma removal with catheters using electrosurgery, et cetera. But I think the big area, Mahmoud, for you guys is going to be the crossover between structural and heart failure, myocardial therapies. And this is kind of an example of one for diastolic dysfunction. Maybe this would even work for HEF, PEF, that would have to be studied, but theoretically you could see how it works. But for HEF, REF, RV, and LV, I think there will be a series of kind of reshaping devices that may or may not sort of support patients on their journey down towards VAD and transplant, or maybe even afterwards. But I think that's going to be the next big jump. You've probably already previewed some of our ideas, but they'll get more sophisticated. And this, using the intramyocardial space as a target for therapies, whether we're cutting or traversing or cinching, maybe it would even be drug delivery. I think that's very exciting. And that's very unique to Emory. There's 2 other centers doing it now, all of them related to us in one way or another, one on the West Coast in Seattle and one up in St. Francis, Long Island area in New York, all of them kind of connected in some way via NIH. But I do see that as an area that we should exploit.
What is the stroke risk when you do this procedure? If you flay open the sesame, there's a rough surface there. So do you keep them anticoagulated for a while, or what is the experience?
Yeah, on our retrospective analysis, the stroke rate was very low. I think we only had 2 patients who had a stroke. And I guess it kind of relates to how we use the radiofrequency in a cutting mode where it's actually vaporized the tissue and cuts open as compared to the coagulation mode where it would cause coagulation in the tissue. So far we haven't seen too much of a stroke. For basilica, initially they were thought to be at a little bit higher risk of stroke, but in multi-center registry, it was low risk, similar to those who have not undergone basilica. And so overall, the stroke rate is low, and we're not necessarily giving, anticoagulation for these populations.
Unfortunately, Tanvir, we've had the privilege to look at these at autopsy also. Things go bad. And it doesn't appear, even when we talk with pathologists, it does not appear to be clot at the base of these things. I think the surface is not abnormal enough to create clot, which is great. There are some protection devices that we use, little baskets up in the neck for some of the leaflet modification. There's some newer things like sleeves that will cover the aorta to capture debris, and that may extend what we can do for patients, because some of the stuff that we do, especially as we work around calcium, can cause stroke. The other thing is sometimes we have a ton of catheters in the aorta for long periods of time, manipulating back and forth, and that certainly can cause stroke, which is the idea that Patrick has talked about, these dedicated devices that would make things very slick and hopefully reduce stroke.
Stan Sherman again, Hiroki. How's your patient doing? The one you presented, and is there an age limit here?
Yeah, this patient was actually the first case of sesame that was done here. And looking through it, she's doing actually very well. Remember, she was having, symptoms just going from room to room. But on recent visit, she were able to tell us that she can walk 1 mile every day. She even went to like a short hike as well. So she's symptomatically doing very well now.
Hiroki, great talk. I think Neil Dickert asked on the chat, what's the minimum septal thickness that we've used? I think if I recall, there was this little as 11, 12 millimeters. We had one case. Vasilis, do you recall?
Yeah, I wrote in the chat. I think, and Hiroki's got the data in front of him, but we've been as low as 12 millimeters for sure.
Yeah, but thicker the better, of course.
Yeah, we feel like it has more, more reserve, particularly if we cut too deep, have more residual muscle, obviously.
Well, I hate to cut off this great discussion, but we're right at 8:30. So thank you everyone for coming, and Hiroki, great job today.
Thank you very much.
The preceding program is copyrighted by Emory University.